That's visible. Yeah.
Visible, visible.
Yes, ma'am, you can start now.
Yeah. So good evening to all of you. On behalf of Gennova and Dr. Preeti Gazbey, welcome you all in today's Youth Thrombosis National Workshop. So the objective of today's meeting is to showcase a rare and complex vascular interventional cases in the neurology, and also share the knowledge and insight with a larger audience across the country. So for this, we have a course director, Dr. Meenakshi Sundaram sir. Sir is a senior consultant neurologist at the Apollo Specialty Hospital.
Ma'am, you're not audible actually. Preeti ma'am, you're not audible actually.
I'm calling Dr. Preeti Kalpita. Just a second.
I think I introduced her in that case. Let's not waste more time.
Hello.
So, good evening, doctor, and a warm welcome to everyone.
And Dr. Preeti joined.
Yeah, please go ahead.
Yes, so as we begin with this session, I would first like to introduce Dr. S. Meenakshi Sundaram. Sir is is a senior consultant neurologist at the Apollo Specialty Hospital in Madurai. He has more than 20 years of experience in neurology, and he has also participated in research work and various workshops under the neurology department. Sir also has various affiliations, including the Neurological Society of India, the American Academy of Neurology, and also the Indian Academy of Neurosciences. And the more feathers in Sir's cap are his major achievements, including gold medal and best ongoing student award for the year 2000 in Enhanced Bangalore. And he has also won the best research award, research paper award at the 10th annual conference of IAN Lucknow 2002. And Sir has around 29 journal publications and 18 book chapters. A very warm welcome to you, sir, for today's session. For our moderator, we have Dr. Bal Murugan Namsivya. He is also a senior consultant neurologist at SIMS Chellam Hospital in Salem. The honors and awards for Dr. Bal Murugan include he's won a gold medal in MD General Medicine. Sir is also won the Ibrahim Bailim Oration on Epilepsy in Tropics. Sir has also won the Best Paper Award at Association of Physicians of India Conference, Diamond Epicon in 2005. Uh, he has also won the Teacher Par Excellence Award 2021 at SCACon and Tapicon, Doctors Day Award, IMA Salem 2022, and also the Best Faculty Award. There are also other awards into Sir's affiliation. Apart from this, he has also contributed. He has also been a contributing author in textbooks, Textbook of Emergency Medicine, Practical Neurology, and the Neurological Examination, and many others. Sir has more than 25 publications, and he has also given more than 100 lectures in national and international medical conferences. And Sir has also been a course director for fellowship in neuro emergencies by the Indian College of Emergency Medicine. A very warm welcome to you, sir. Our next moderator for today's session is Dr. K.K. Prachet. Sir is also a senior neurologist at the Kongunad Hospital in Coimbatore, and he has around 25 years of experience with key areas of interest including headache, demyelination, and stroke. Sir is currently working as a senior consultant neurologist at the Kongunad Hospital in Coimbatore. A very warm welcome to you, sir, as well. Our speaker panel for today includes Dr. Satish. Sir is a senior consultant neurologist at the KMCH Hospital in Coimbatore. Sir has presented in Shine 21 at the 11th International Conference of Clinical Neurology. Sir has also presented an e-poster titled Case Series of Pediatric Stroke and has also secured first place in e-poster titled the Master Stroke Case on the Master Stroke Case Series of Pediatric Stroke. he has also presented a rare case of movement disorder with developmental delay, a case report and review of literature published in the Indian Journal of Neurology. A very warm welcome to you, sir, as well. And our next speaker for today is Dr. Srivardhan. He is a senior consultant neurologist at the MGM Healthcare Hospital in Chennai. Sir has been honored with the
Yes, yes.
President's Sir has been honored with the President's Gold Medal in Neurology in 2022 and DM Neurology Gold Medal in 2021. Apart from this, Sir is also an accomplished clinician and academician with multiple national gold medals across MBBS, MD, and DM. He has also been recognized as the best outgoing MBBS graduate of the year by JIPMER in 2013 and is also the topper in MD. He has been actively contributing to neurology education as author of Brazis, De Jongs, and Viller's textbook editions. Sir has also presented various papers and has around 10 original research studies in peer-reviewed journal. His special interests include rehab neurology, migraine and pain management, and also neurocritical care. A very warm welcome to you, sir, as well. With this, I hand over the session to Dr. Meenakshi Sundaram to please take it ahead. A very warm welcome to all the doctors once again.
Namaste, madam. Very happy to be sharing this podium with the two of my close friends, Dr. Prachet. We were batchmates in Niman's neurology, and my mentor, Dr. Balmurugan, with whom we shared several moments, including lighter moments, and he has taught me a lot. Thank you for being with us in the same platform, and very importantly, stroke is learned, case by case. It's that we say that Dr. Adams writes that you learn neurology stroke by stroke. So it's a very welcome move by the Gennova and group for educating us every month with this wonderful program. And without much ado, we can go into the cases. Two presenters, one Dr. Satish Shanmugam, well known to us from KMCH, and then the other person, Dr. Srivardhan. So I have worked with Srivardhan closely in the books which you mentioned, madam. He has taught me a lot in those days during Corona period. Almost 1 year we used to have sessions, and he is one of my gurus. Thanking you all. And without much ado, I hand over the mic to Dr. Prachet and Dr. Balmurugan for their open remarks, and then we can go into the cases. Prachet, take over.
Yes, I think we'll start off with the case presentation, then we'll take it as it goes.
Can we invite the first speaker to present his case, please? Dr. Satish.
Good evening, sir. Good evening.
Namaste, Satish. Welcome.
Yeah, sir. Yeah. So I'm Dr. Satish, sir. So I did my MBBS in Coimbatore Medical College, and I did my DM in Ramachandra, and I did my stroke fellowship in CMC Vellore, sir. At present, now I'm currently working in KMCH Coimbatore. So
Welcome, Satish.
yes, sir. So I'll just go into the topic per se. Yeah. So is my screen visible now, sir?
Not yet.
Once. Now, sir?
Yes, sir.
Yeah. So it's a great honor to present here, sir, in front of you all. So this is a very common case, but I just want to highlight some of the details which we use to work up in as you told, stroke has so many branches in it. So even small things matters in stroke management. So, so this is a 45-year-old female who presented with complaints of acute onset of weakness of right upper limb with language dysfunction. No prior comorbidities. She did not have any preceding headache, vomiting, or seizures. And on examination, the patient was aphasic. She was having Broca's aphasia. She was oriented with a differential weakness. So the clinical localization was more onto the left frontal cortex, and the vascular territory involved was
Satish,
like the
Satish, you have to
superior.
move your slide, Satish. Hold on, please.
Yes, sir.
You're not able to see the slides. Only it stays with your first slide, I presume.
1 second. 1 second.
Initially, make it full screen and then go
Yeah.
ahead, please.
1 second.
Yeah, that's more like it. Yeah. Are you able to hear him, Prajit?
No.
No, you have muted yourself, I think.
Please unmute, sir.
You can start from the first. You can start from the first slide from the history before this. Yeah, you could start once again for us. Thank you, Satish. Thank you.
Sorry, sir. Sorry for the delay.
No
Is it
issues.
okay now, sir?
Yeah,
Yes.
yeah. Now it's fine.
Yeah, fine, fine. So this is a 45-year-old female who presented with complaints of a weakness of right upper limb with a language dysfunction. She had no prior comorbidities or she had any prior headache, vomiting, or seizures. On examination, she was aphasic with a differential weakness. So the clinical localization was more to the left frontal cortex, and the vascular territory was more of likely to be the superior division of MCA. So when we imaged her, this was the brain imaging, which showed an internal as well as an external watershed infarcts. And the MRA showed left supraclinoid ICA narrowing, and there was a paucity of flow in the left MCA. So initially her NIHS at presentation was 7, sir, with an aspect score of around 7. Sorry, NIHS was 5 and the aspects of around 7. So we went ahead with lysis. Since the NIHS was not nearing around 6, we didn't directly take her up for a DSA. So what we did was we initially lysed her with tenecteplase, and following lysis, there was a worsening of NIHS. So the possibilities thought were it could be whether it was a post-lysis bleed or an infarct progression. So we repeated the imaging, and the imaging remained static. There was no infarct progression, and the vascular territory was also the same. But what we had was there was a worsening of NIHS. So there was a clinical radiological mismatch, and hence we took her up for a DSA. So this was the DSA. In DSA, what we could see is when we took a ICA run, there was a left supraclinoid narrowing, but through the ECA, the collaterals were filling off, and there was a good collateral circulation which was happening through the ECAs on the left side. And this patient also had a very good collateral circulation from the PCA also, sir. So we didn't proceed further with a thrombectomy per se. So we like what we planned was to go ahead with a good best medical management. So she was started. She was started on antiplatelet therapy and high dose statins. So initially, we post thrombolysis after 24 hours, we started her on ticagrelol with aspirin, and with we loaded her with the statin of around atravas of around 80 mgs. So one thing was she didn't progress as such. We just maintained the hemodynamics, and we maintained her BP on the higher side, so that the collaterals could remain open. The basic routine blood investigations were done, and the CBC, RFT, and electrolytes were under normal limits. since she had no prior comorbidities, she was worked up for the vasculitic profile also. So the ANA, ANCA, C3, C4 were normal, and the thrombotic workup was also negative in this patient, and APLA workup was negative. So this patient was worked up for a non-atherosclerotic vasculopathy. As we all know, like any female patients, young female patients with the progressive narrowing of the supraclinoid ICA needs to be worked up for other non-atherosclerotic vasculopathies like FMDs and Fabry's disease, especially in females, young females. But in case of a Fabry's, we tend to see these dolichoectatic vessels, but this lady did not have any dolichoectasia as such. Only thing which we could find out was supraclinoid narrowing with a paucity of flow in the left MCA. But there were good adequate collaterals which were filling off, but we couldn't see much of moya vessels as such, sir. So we did the genetics. Sir, am I there, sir? Am I audible?
Yeah. Yes.
Yeah. So we proceeded with these ICAT genetics, and SVD genetics were also sent, which was initially negative in this patient, and this RNF 213 gene mutation was also negative for her, and cardiac workup and Holter monitoring were normal. So like the other causes for a large vessel progressive large vessel occlusion were worked up for. Her serum homocysteines were also under normal limits, and there was no MTHFR mutation also in this patient. So I proceeded on with the vessel wall imaging. This vessel wall imaging showed some amount of enhancement in the left supraclinoid ICA. But the problem with this left enhancement in this cavernous segment and the supraclinoid segment is there will be a lot of these vasovasorums vessels supplying these areas. So the contrast the enhancement in these areas are not taken into much effect. Hence, I couldn't make much out of this vessel wall imaging. So what we did was we proceeded on with a CSF analysis to rule out any primary CNS angiitis. So the CSF analysis revealed a mild elevation in the protein as such. And the glucose were under normal limits. And since it was involving the M1 segment, the proximal M1 segment, varicella antibodies were also sent, which were also negative in this patient. Then we proceeded with a TCD to monitor how her vasomotor reactivity was. She had a good vasomotor reactivity. Her pulsatility index was also on the lower side, so she didn't have much of a resistance in the MCA flow. And we did a TCD bubble contrast. So this TCD bubble showed some amount of hits were also there, sir. Some amount of shunting was happening. So there were some amount of hits which were going on in this lady. So those were the hits which we could find out. So though it was a large vessel disease, I couldn't ignore these hits also, because uh, there were quite a few even without doing a Valsalva manual. So when we calculated the rope score was coming around 7. So I proceeded on with a transesophageal echo, which revealed an ASD with like a PFO with a defect of around 5 mm, but there was no any aneurysmal ASDs or as such. So the Pascal score was calculated, and it was more likely to be a possible PFO. So like now, like we were caught in like how to treat, how to go ahead with this patient. Because she had some amount of some amount of shunting, right to left shunting was also happening, but the stroke was more likely to be a hemodynamic stroke with an internal as well as an external watershed infarcts. Since there was a mild elevation of the proteins, and going ahead with the age factor, we immunomodulated her with a pulse methylprednisolone. Actually, her power improved post pulsing with methylprednisolone, and a second line was planned for. Though we initially planned for a cyclophosphamide, but we didn't go ahead with hitting her very hard. So we started on with an MMF and low dose steroids, steroids to be followed, low dose steroids were also given for that lady, along with DAPT and statins. So at present, she's doing well. Her MRS at discharge was around 1, and she was and her aphasia was also improving quite significantly, and her upper limb power also improved to around 4 plus at the time of discharge. So one thing I wanted to highlight here is any patients with a progressive supraclinoid narrowing, before jumping into the diagnosis of moya, like moya as such is a bilateral disease, but this lady had more of a unilateral disease involving the left supraclinoid ICA and the left MCA. So, though there were not much evidence to start on immunomodulation, considering the age and considering the progression in the symptoms, we pulsed her with steroids, and she had a good amount of improvement with steroids and her statin as well as the antiplatelet therapy. So I kept her under follow-up. Initially, she had persistent headaches, especially her early morning headaches. One thing what I suspected was during this sleep, there will be in view of an increased vagal tone, there might be a shunting to the opposite side. So I did a TCD again for her, but there was no and I did a vasomotor reactivity, but there was no reverse Robin Hood phenomena was not seen in this lady. So, so what we did was we kept her under a gradual, a good follow up. And as of for now, there are no new influx, and the disease is not progressing as such. So, as of for now, we have not planned on any anastomotic surgeries as such. She's at present she's doing well with medical management. So this is the one case I just wanted to highlight. These are the workup which we did for this female patient. Though she presented initially with a watershed infarct, she was more into the territory of vasculitic, whether it was a primary CNS angiitis or it could be some other non-atherosclerotic vasculopathy. Uh, Taking the benefit of doubt, she was started on both immunomodulation as well as antiplatelet therapies. So thank you, sir. Thank you.
Thank you very much. You may,
Yes,
yeah.
sir.
Thank you, Satish. That was a nice case. You
Yes,
took
sir.
us through a long pathway. So I may have some doubts to ask you. Before that,
Sure,
can I
sure, sir.
request Dr. Prajay to put forward his thoughts?
Now, my question is, what was the LDL at admission?
Sir, LDL, sir.
LDL,
LDL was around 70, sir.
70. Okay.
Yes, sir.
See, there was watershed infarct.
Yes, sir.
Okay, and there is a supraclinoid stenosis and there is an MCA stenosis also.
MCS. Yes, sir. Yes, sir.
Okay, so that watershed infarct may be contributed to some extent by these two stenosis.
Yes, sir. Yes.
Okay,
Yes.
so
Yes.
my question is, why can't this whole thing just be atherosclerosis?
Yes, sir. Atherosclerotic other risk factors were not there, sir. All other, her BP was on the normal side. She did not have the normal vascular risk factors as such, sir. Her sugars and as well as her cholesterol were all in normal limits. That was the only thing which was happening in this lady, sir.
Okay, and second thing is, agreed that okay, it's a tough call only, but
Yes.
how do we say that the patient improved because of methylprednisolone?
So we couldn't say whether it was just the immunomodulation. So what we did was I just maintained her hemodynamics. We didn't
That's
lower
all.
the BP as such, and the progression was not there as such. But one thing which was striking there was in the DSA also, sir. Like what we could see is there was some amount of spasms which are going on. So that was the only thing which made us to think whether it could be an ongoing vasculitic process. So just giving the benefit of that's why we didn't start her with cyclophosphamide. I didn't want to hit her hard with cyclo also, sir.
And what about
So
varicella? What was done? Both IgM and IgG were
yes,
done?
it was we did we sent IgM, sir. IgG was not sent as such.
See, the problem is this I learned from Balamurgan only.
Yes,
See,
sir.
because it's a reactivation, varicella in inflammation inside the brain,
yes, sir.
because it's a reactivation, you will not get a high IgM.
Yes, sir. Yes, sir.
IgG alone will be high. So
High,
it could
yes.
still be varicella.
It could be still be. Yes, sir.
We had a similar patient around 4 months back.
Fine,
Same
sir.
focal TIA, 2 episodes of TIA,
Fine,
focal
sir.
stenosis of the MCA,
Yes.
IgG was very high.
Oh, fine, sir. Fine, sir.
And then we gave him acyclovir, IV acyclovir.
IV acyclovir. Yes, sir.
Then
Yes,
we put him on this. I haven't done the repeat imaging still, waiting for 6 months. So probably
fine.
by February, March, I will do.
Fine,
So
sir.
one thing is that IgM may not be very sensitive in this
Yeah.
situation. So
Yes,
if you
sir.
want to rule
We
out
should-
varicella, do IgM and IgG. If IgG
Sure.
is very high, you can still consider possibility of varicella.
Varicella vasculitis. Yes, sir. Sure, sir. Sure, sir.
Thank you. Thank you, Prachit. So is Balmurugan with us, Prachit?
Thought I heard his voice in between. I'm not
Okay.
sure.
Now, I have some doubts to ask you. So that's a nice presentation, Satish. And the
Sure,
patient
sir.
is doing well. We are very happy about it, really.
Yes, sir.
It's a
Thank
tough
you.
call. You went through several steps to
Yes,
clarify the etiology. And
yes.
still, as we had seen many patients, the etiology is still elusive. I don't
It's
think the
still
book
not.
is shut as said.
Yes, sir.
The patient requires more follow-up. Now, I have certain doubts on behalf of the audience. I may ask you a few doubts.
Sure, sir.
So the first thing is that first you gave tenecteplase. That's a correct treatment to give, irrespective of the etiology. That's what you actually
Yes.
told us.
Yes,
When
sir.
we see a patient in the emergency, we don't have to worry about what is the cause of the stroke.
Yes.
Straight away go and thrombolyze them. That's the
Thrombolysis.
exact
Yes.
thing what we would have done, and that's a very nice thing you have done.
Yes.
So doing the right thing at the right time. The second thing we'd like to clarify from you is as follows. The point
Yes.
is, this patient received thrombolysis. On day 2, you started the patient on ticagrelor.
Yes, sir. Yes, sir.
In fact, dual antiplatelet, which includes ticagrelor.
Ticagrelor and aspirin, sir.
Yeah. So we have certain specific recommendations for ticagrelor. There should be an arch involvement. There should be a documented big carotid involvement.
Yes, sir.
Probably it was a carotid involvement which pushed you to use
Yeah,
ticagrelor.
that carotid alone, like whether I was biased, sir, whether to start on clopidogrel or to go ahead with ticagrelor. But since that was a progressive narrowing of that supraclavicular ICA, and it was around 80% stenosis was there, sir. So I just wanted to start on ticagrelor at
Yeah.
that time.
So it is what just highlight the use of ticagrelor in patients who come with acute ischemic stroke. So
Yes.
what are the indications we will use just to make it clear for people who are viewing this that we would
Yes.
use it in a large vessel disease and you should have an ipsilateral carotid stenosis
Yes.
of any nature. It is not clarifying that it should be a high grade stenosis
Yes.
or there should be an aortic arch involvement and then you go and use ticagrelor because
Yes.
otherwise the drug has its own issues.
Yes.
The second thing we want to learn from you is that after thrombolizing and ticagrelor, doing a CSF examination is a very brave thing. So how
Yes.
long did you, sir? Because it's
So
recommended that, yeah.
Yes, sir. Sorry. So we stopped that antiplatelets for 3 days, sir. It was a tough call whether to stop because we had to go ahead with a CSF analysis also. Like before starting on, we needed some evidence to start on steroids, sir. So what we did was we just maintained the hemodynamics and we stopped the antiplatelets for 3 to 4 days. In fact, we stopped for 4 days, sir. Then we went ahead with CSF analysis and following CSF analysis only, we started on steroids.
Yeah. For postgraduates who are here with us, ticagrelor is a drug which can produce definite spinal hemorrhage. So we need to be aware of that. The recommendation in a non-emergency situation is to withdraw this at least for 5 days and do it. In an emergency situation, if there is absolute necessary and you are able to say that this is a life-saving thing, you can go ahead and do it after explaining to the patient. So that's a
Yes.
recommendation for ticagrelor when you have to go ahead and CSF. That's a learning point. We have to learn how long to stop ticagrelor in this given case. That's the most important point, I feel. The next thing is that the indication to use steroid in a patient who has come with an acute ischemic stroke.
Yes.
So could you clarify for the viewers as to what are the indications you would think would be essential for us to say this patient will be put by me on steroid? So 1, 2,
Uh,
3, if you can tell us.
yes, sir. So So if we suspect any primary CNS angiitis as such, so when to start on steroid is still like in acute condition, it's still a dilemma, sir. Like especially in such patients, whether it is just the normal atherosclerotic changes, or is it any other angiitis which is taking in charge of uh, uh, this stenosis, is still a debatable thing. One thing is the age, sir. Age without any much of vascular risk factors, and the territory which was involved. It was more likely to be the MCA and the ICA territory, which was large vessels which were involved. And actually, I forgot to mention, she had a preceding headache also, sir. Headache in stroke, we need to be a bit cautious. It could be because of these vasospasms and vasculitis, because these are the conditions where we can have the headache, which then goes on to develop a stroke. So that is one indication we take in to start on steroids. And second one, in this lady, as we saw, like there was a mild elevation in the proteins. CSF protein was slightly elevated, sir. It was around 63 in this patient. So that was a slight indication, to go in with the steroid therapy, with an immunomodulation therapy. That is another indication to start in this patient, sir. And as I already mentioned, this vessel wall imaging, sir. This vessel wall imaging, if it was not for that supraclinoid portion, and if it was just the MCA which was highlighted, then definitely we would have had a supportive evidence to start on the steroid therapy, sir. Because these cavernous segments and these supraclinoid segments, they have a very rich vascular supply. So there will be a lot of contrast enhancement in these two areas, sir. So just going ahead with the vessel wall imaging in these two areas is a bit of dilemma, and the type of enhancement is also very important. Whether it is a concentric enhancement or it is more like an eccentric
Eccentric
enhancement.
investment.
So that 2 points were also taken into consideration before starting on steroids.
So thank you. So the idea to give to our viewers is that number one, you use steroid in a patient whom you consider vasculitis. The common thing which would affect that segment could be Takayasus or a giant cell arteritis.
Sure.
These two could be the reasons why the patients can develop stroke. And vessel wall imaging, very importantly, showing a concentric enhancement would make us more persuasive in starting steroid in an otherwise and this one difficult patient. So these are the things which we need to learn from you. And I have other doubts to ask you also, Dr. Satish. This is only to just highlight certain points for discussion.
Sure,
So
sir.
the point is, when you look at that area, what can be affecting that area is one, as you said, it could be fibromuscular dysplasias.
Mm.
Rachit also told us about atherosclerotic involvement in these areas, and
Yes,
you highlighted about a vasculitis also affecting this.
yes,
And Moyamoya syndrome, we actually went through this. Even
but
though it is unilateral, still you could have to consider
still
Moyamoya.
it
These
could be,
four
yes,
causes together.
yes,
But one cause always lingers through my mind, my naive mind. Excuse me for
yes,
asking this. The question I always go through is that, is it a migraine? Is it a dissection?
yes, sir.
Because these issues happen because when you said headache,
Headache,
young
yes,
person,
yes,
dissection is an important etiology, and then
yes,
we'll be overburdening the patient with steroid. So
still.
could you have show some, light on this etiology as well?
Yes, sir. So these vasoconstrictory syndromes, sir, we need to consider all these vasoconstrictory syndromes, especially in patients who are presenting with headache and strokes, sir. So one such thing was this migraine with infarctions. Migraine with infarctions. One thing is she was not a prior migrainer as such. Like previously, she was not having any such. This was the first time she experienced this sudden thunderclap like headache. So that was the only thing which was against calling it as a migraine with a hemiplegia or migraine with an infarction. But still, as you mentioned, sir, still migraine with a vasoconstrictor syndrome is also another possibility in this lady, sir, considering the
And about
age.
dissection,
Yeah, dissection. The most common site of dissection in case of intracranial vessel is near that where we have the sphenoidal bone, no, sir? That area. we have that sphenoidal wing, so that the proximal segment of the MCA is the most common site for dissection in case of an intracranial vessels. Whereas in extracranial vessels, we could see 2 centimeters above the bifurcation of the ICA is the most common site of dissection in case of an extracranial. But in intracranial vessel, that MCA near that sphenoidal wing, the greater wing of sphenoid, that area, that segment is more prone for dissections. And DSA was also not much in favor of a dissection in this patients.
Because when we are going to give steroid, so might
Yes,
as well go through these etiologies with the
sure,
more
sir.
intention to look at for this. That is the reason I brought up these issues.
Yes,
Nothing to say otherwise. So
sure.
there are points which we learn from the cases as follows. Number one, the use of ticagrelor in practice. Always the routine use of tenecteplase and then the use of ticagrelor. How to go about doing lumbar puncture in a patient who has been treated with antiplatelet therapy. That is the second point. The third point we learned what will be the etiological factors we need to consider in patients who have an intracranial occlusion, like you showed the supracranial unilateral stenosis. What are the etiologies to consider? And number four, when and how you will go about with steroid therapy.
Yes.
I think these were the four learning points from your case. If you have anything else to share, please let us know. Prachet, anything else we need to discuss here, Prachet?
No, that's
Anyway,
it.
thank you very much. So give us a feedback on this case in a future presentation as well. Best wishes. Thank you, Satish. That was a
Thank you,
great
sir.
presentation.
Thank
Thank
Can I
you,
request our next speaker, Dr. Srivardhan, to come forward? Srivardhan is a brilliant neurologist, my guru. Gurunada, you can take over.
Thank you, sir. Thank you for the introduction. Um, we had a very interesting case by Dr. Satish. I'm going to not delve into such high topics or fancy diagnosis. I would rather stick into the basics of thrombolysis. And we have a lot of younger neurological colleagues like me and some of the postgraduate students who should know that the indication for thrombolysis keeps expanding, and we now have newer modalities and newer techniques which can help us in guiding the treatment. So it's not a single case, it's rather a compilation of multiple cases to just show to the younger colleagues of mine. So when we are talking about the reperfusion therapy in acute ischemic stroke, in the first 4.5 hours, we have thrombolysis and thrombectomy. 4.5 to 6 hours, we have thrombectomy. And beyond 6 hours, we use the concept of tissue window, which can be either DW flare mismatch or core penumbra mismatch. And this is the classical table which we use with so many contraindications and relative contraindications for thrombolysis. Without going further, I'll directly jump into our cases. The first case is a 60-year-old male, known case of hypertension with mitral regurgitation and pulmonary hypertension on medications. He was on a low dose of a beta blocker. He woke up normally, developed sudden onset slurring of speech at around 8 o'clock, and he reached the hospital by around 3 o'clock because he was on a train. On examination, vitals are normal, had a mild right facial lag, significant dysarthria, mild pronator drift with an NHSS of around 4 to 5. There was no prior history of stroke or TAE. I'll play this video. Hope the audio is also clear. And it address but all the body அளவுக்கு இது நம்மால் பற்றி total. Number 12, Dubai. So he had a significant dysarthria. The word Subbarayan, he had a significant problem in uttering. Other than that, there was no major weakness. So since he had come outside the window period, we directly proceeded for MRI and not the CT. So I have just kept the DWI, ADC and flare images. We can see a subtle DWI hyperintensity in the left frontoparietal subcortical white matter extending into the coronary radiata. with the ADC hypointensity. The corresponding flare sequences are not showing any significant hyperintensity. We are seeing some Faseca small vessel ischemic changes bilaterally, but this is not corresponding to that. So this is what we refer to as a DWA flare mismatch. This was the MR angio of the patient. And you can actually see the clot here. The clot was actually located in one of the M3 branches, the cortical branches. And our ASL was able to identify the clot as a bright spot. So we thrombolized the patient. DWA flare mismatch is an approved indication for thrombolysis beyond the window period. And this is the audio of the same patient the very next day. So if you notice the Subrayan in the first video, so this is the significant improvement in the dysarthria which he had. Why this is important is this subtle symptom. The patient was actually a teacher by profession. The dysarthria might be a very subtle symptom. The NHSS of 4 to 5 might mean that on paper it is a minor stroke, but the dysarthria can be potentially disabling for the patient. So any neurological symptom needs to be taken seriously, and a simple intervention like just a thrombolysis, which can be done in any center, can change the outcome of the patient. So I'm also giving a second case similar to this. A 75-year-old male, diabetes, hypertension, coronary artery disease, status post PTCA on dual antiplatelets, had a wake-up stroke. Left hemiparesis, power around 4 to 5, dysarthria with sensory inattention. NHSS was 8. Vitals are stable. His blood pressure and sugar control were fair. I just am demonstrating a video here. So I'm demonstrating visual extinction here. When we stimulate the visual field individually on the right side is able to identify the right side, individually on the left side is able to identify as the left side. But when we do it simultaneously, is finding it only on the right side and is neglecting the left side. So the neglect is not only for sensory, it is also for the auditory and the visual stimuli. Again, wake up stroke. We did an MRI directly, not wasting time in the CT. And this is the MRI. We can see a acute or rather an hyperacute infarct, the DWA hyperintensity with an ADC hypointensity involving the coronary aorta and right frontoparietal white matter, also extending into the posterior insula. This is the MR angiography. We can see that there is an occlusion of the M2 segment. This is the M1, the superior division of M2, the inferior division of M2 is not seen. And you can actually see the clot here, which is seen as a hypointense or a dark spot. And I have kept the corresponding flare sequences where we can see a partial flare mismatch. This is not a complete mismatch. You can see some subtle hyperintensities in the right frontoparietal subcortical region. Similarly, in the insular region, in the original paper submitted by Tomel Lab, it was not just the DWA flare mismatch. A partial mismatch defined as less than 1/3 involvement in the flare is also considered a significant mismatch. So we proceeded with the thrombolysis in this patient as well. Again, here you can see the ASL showing an hypoperfusion. So there is not only a DWA flare mismatch, there is also a DWA perfusion mismatch. This entire division, which is supplied by the inferior division of M2 or the MCA, is at risk of going into an ischemia. If left untreated, this entire region is going to become infarcted. So this is the DWA perfusion mismatch. So as mentioned, the patient had both DWA flare and DWA perfusion mismatch, thrombolized with tenecteplase, excellent improvement. At discharge, even the extinction completely disappeared. I couldn't take a video of that, but his NHSS at discharge was 0. These are some of our other patients with subtle DWA flare mismatch, where we use MRI guided DWA flare mismatch as a indicator for selecting and thrombolizing patients who present outside the traditional window period of 4.5 hours. And the hallmark study for that was the wake-up trial. Coming to the next case, 74-year-old male, diabetes, hypertension, chronic bronchitis, benign prostate hypertrophy status post-CHIRP, hyperuricemia, coronary artery disease, vitiligo. He takes around 13 to 14 tablets per day, polypharmacy. Good compliance and good control of diabetes and hypertension. He presented with an acute onset of slurring of speech for 45 minutes. Examination was completely normal except for the isolated dysarthria with an NHS of around 2. I'll play the video. So this was the video taken immediately after he entered the emergency room. You can notice that we are still doing the triage, checking the blood pressure, checking the CBG and all those things. So this was the dysarthria. There was no facial weakness. There was nothing to suggest any oromotor apraxia. So by protocol, immediate 45 minutes, we did a CT brain. CT brain was completely normal. So now comes the next question. Are we justified in thrombolizing the patient or not? We thrombolize the patient assuming a possible stroke in the coronary aorta or ponton infarct, which can present as an isolated dysarthria without any limb weakness. And we didn't want to waste time doing MRI before the thrombolysis. Post thrombolysis, we did an MRI. MRI is completely normal. We can see prominent Virchow-Robin spaces in the T2 sequence. Other than that, there is nothing to suggest an acute infarct in the coronary aorta or anywhere in the pons. The MR angio shows no evidence of any large vessel occlusion. This is the perfusion imaging, which doesn't show any hypo or hyperperfusion. This is the video of the same patient that evening after shifting to ward.
MS Paras, F first F1 32/71 Pajaliman Point Street, Arumbakam, Chennai 106.
So you can see a dramatic improvement in the articulation, the dysarthria part. So this particular case I had put here mainly to discuss a few topics. Number one, was a thrombolysis justified in this patient? Number two, in hindsight, if the MRI was taken first and if it was found to be normal, can we still proceed with thrombolysis? So these are two important learning points which I personally got to experience firsthand in the management of this particular patient. So to answer that, we'll just go to what the American Stroke Association's latest recommendation says. So for mild non-disabling stroke, thrombolysis is not recommended. But they use the word non-disabling stroke with NHSS up to 0 to 5. But we can expand this indication a little further. This is from Up to Date. I found it very interesting where they have broken out what is a disabling and non-disabling stroke a little further. Patients who have persistent neurological deficit that is potentially disabling, despite improvement of any degree, should be treated with thrombolysis in the absence of other contraindications. Any of the following should be considered disabling deficits. Complete myopia, more than 2 on the NHSS question 3. Severe aphasia, more than 2 on the NHSS question 9. Visual or sensory extinction, more than 1. Any weakness limiting sustained effort against gravity, more than 2 on the NHSS question 5 or 6. Any deficit that leads to a total NHSS more than 5. And most importantly, any deficit considered potentially disabling in the view of patient and the treating practitioner. So this patient does not have an aphasia. It was rather a dysarthria. So if you go by this criteria, it doesn't fit into anything, but it is a potentially disabling symptom. A patient who's not able to articulate is a very potentially disabling symptom, and we were justified in thrombolizing. So this answers the question one. Was thrombolysis justified? Even though it's a minor stroke, it is justified. Now coming to question two. If the MRI was taken first and normal, can we still proceed with thrombolysis? Going into the literature, we found that MRI negative strokes are actually quite common. And this was one of the large longitudinal study published in 2015, where the pooled estimate of the proportion of patients with DWI negative non-disabling stroke was around 21. Here the definition of non-disabling stroke was any NHSS less than 5. So if a patient presents with a minor stroke, NHSS less than 5, and if the MRI is normal or the DWI is normal, there is still a 21% chance that it is a false negative report. This was another paper published in the Green Journal in 2017 about the diagnosis of DW negative acute ischemic stroke. And there the pooled prevalence was around 6.8%. So this answers our second question. In hindsight, if the MRI was normal, if you think it could have been a TAA, we are probably medically and scientifically still justified in giving thrombolysis. Sir, before going to this case 4, if you have anything else to add, we can take a break here, sir. Because this is a very, I think, a contraindicating or a conflicting opinion which I have given about thrombolizing minor stroke. So if the chairpersons or moderators have anything to add here.
See,
No,
I feel that we can discuss these 3 cases and leave the 4th case for open following that.
Yes, sir.
So, Prachit, your views on the cases. So, see, as usual, phenomenal cases. See, phenomenal.
Thank you, sir.
Yeah, I think very good. You have put forward your case very strongly. I think that is the way it should be, because we need to thrombolize all the disabling strokes. We need to find indication to thrombolize and not contraindication not to thrombolize. This is the famous words of Dr. Nasli Ichapuria, sir. So he says this often. And the point is, it's very easy to talk at this. Suppose the patient comes with NIHs of 4, you don't thrombolize. After 2 hours, NIHs become 20. What do you do? So I think you are perfectly justified. And regarding this DWI negative stroke, that is, I think the figure 6% is accepted.
Exactly.
21% maybe, I think, too big a number. And 6%, and this is
Probably their justification was that was in 2015 before the availability of better MRI machines. By
maybe.
2019, probably we had much superior machines, and that was the justification actually given in the study, sir.
Yeah. And so this scenario is much more commonly seen in posterior fossa circulation rather than in anterior fossa circulation. So, and there, in fact, what they do is radiologists, sometimes I think they do the coronal DWI sequences, and just to make sure that they are not missing any strokes. But it is perfectly justified. What you did is 100% correct. I think you have driven home the point. This is very useful for the PGs, because when anybody starts, even when we started, when all of us started, we were very skeptical of thrombolysis. We are more afraid. This is the fear which always has. But generally, over the years, what I've had is, see, even if the indication is wrong, it's okay. But you have to be very, very clear about the contraindication. See, if contraindication is perfect, then generally no problem will happen. But if there is some mistake in indication also, it's okay. For example, in the middle of the night at 2 o'clock, I thrombolized 1 or 2 patients with postictal seizures also. Okay, so this has happened because we didn't have MRI at that time. So many things were there. So this happens. That is okay. But if your contraindication has to be pakka, so then it is better to err on this side. And Dr. Subhash Kaul used to put a famous poster that boy wanted to pass urine, okay, and he just went to the roadside and passed urine. He didn't look for toilets and things like that. So basically, if you want to thrombolize, you just thrombolize. So make sure your contraindications are okay and thrombolize. It was very good. Thank you for the wonderful cases. I think Dr. Sundar, you can add something.
Thank you, Sri. It was really enlightening, really. Now, there are a couple of things which I would like to add us. Now, to tell the viewers why this issue of NHSS 4 and 5 have come. The basic premise for this came from a study called the PRISMS data by Dr. Pooja Khatri and colleagues, who tried to see how good it is to thrombolyze patients who have got minor strokes. By definition, an NHSS of 5 or less was considered as a minor stroke. So we are on one hand going to thrombolyze the patient looking for reaping the benefits of thrombolysis, which we have demonstrated so eloquently in all the three cases, vis-a-vis the complications which Pratesh mentioned in the form of hemorrhage. So how are you going to match that? And the misfortune, I say misfortune because Pooja Khatri madam's data said that minor strokes actually do not get benefit out of thrombolysis. The risk outweigh the benefit. And that's where everything started, becoming more hazy for us. But I would make it quite simple. The reason you always have to follow the footsteps of cardiologists. Now, if you look at the cardiologists, do they really care what is a myocardium? Is it mild? It is more? It is severe? You see a patient with chest pain, you do an ST elevation in the MI, in the ECG, go and thrombolyze. Today, at least, we are looking at trophy and those things. Remember, 10, 20 years ago, did not have trophy and anything. The CPK is likely to be normal. Go and thrombolyze. No harm is going to come after it is done in good faith. So I don't believe that there should be any contraindication. The second thing are the 5 settings you showed us that when a patient has got a minor stroke, when you say minor stroke, people will think NHS 5 is minor, as you have so correctly put in that slide. A hemianopia complete would be NHSS 2. And if he doesn't improve, he can never drive, and rather he would not be even able to walk to the toilet. As the extinction is a really problematic thing. So, and that is the reason why the last thing, the last point of your slide, that clinched it, in my opinion, that said that any deficit which is potentially considered disabling by the patient or by the doctor. Look at that clever wording, I believe, is a lawyer language. It's a completely legal language for us to use. And that is exactly what we do in our practice. I had a patient, I'm recollecting this patient, who came with only sensory deficits. This was much, much before probably 2005 or 6. We did not know any of these things or those things. That is the NIH criteria and all those things did not exist. For us, stroke means to thrombolyze. When I saw this patient, only some mild sensory deficits he had. We had a discussion about the stroke thrombolysis and we did not do for that patient. I did not offer, frankly speaking. Knowledge was limited. Later on, the patient haunted me because the patient continued to have sensory deficits. And when I used to tell him, "Ennaga, I have got some mild numbness you can ignore," he asked me this important question. Is it okay for you to have numbness on one side of the body? So I could never answer the question. Every time he would come, he would have a long discussion with me and make a lot of chat with me and waste my time. But he would plunge his point into my chest that you didn't thrombolyze when I came because that is what I came to you for. And those times the awareness was not much. These are IT guys, would come with awareness and trouble you. The idea is that the ball should be on the patient's court. Nowadays, what I do, if I think it is a minor stroke, I ask the family, I ask the patient's family, you think that it is okay to thrombolyze, we'll thrombolyze. From my side, I think it is important for me to thrombolyze. Like you have said, for me, I'd like to go ahead and give it. I don't want to experiment. As Rajat said, I don't want 6 hours later a major stroke and we are, cutting a sorry figure. I'd say, please go ahead. There is no excuse for not thrombolyzing. That's the rule we must follow. Dr. Vijayan used to tell us from Coimbatore, used to tell Satish colleague used to tell us the same thing. So the ball is on the court of the family. If they say after this, no, we don't want, that is their headache. We can't do anything about it. But from our side, I would always consider any symptom as potentially disabling. be it is a minor sensory symptom, a minor dysarthria, obviously we should consider disabling enough that we should offer thrombolysis because the patient has come in the right window. The second thing I always tell our postgraduates as well as every colleague is that do not do MRI within the 4.5 hours window because it will induce so much of doubts in your mind. That is when you start feeling negative about it. So just to do a plain CT, no hemorrhage, thrombolysis. Then the idea would be sticking on to us very heavily. We will not have any other contraindications coming to our mind. CT, no bleed, less than 4.5 hours, go on thrombolysis. The real issue which I faced in the past is what you also told us that when the patient completely becomes normal and the next day imaging is completely normal, the patient would not say anything, but there will be one uncle whose relative lives in US who are going to ask, sir, why did you thrombolyze? It was not required at all. There was no stroke. And in the WhatsApp era, we are going to face, for which an answer was taught by my brother, which I always tell the family. I asked them, which is the best report on an MRI you would like to see? I give you two scenarios, a big tumor sitting there, a big hemorrhage sitting there, a big infarct sitting there, and choice number 4, normal MRI. So you put that across, they would now understand what you're trying to say. Ready fellow, I have given you a treatment which did not allow even infarct to set radiologically. It might have been there microscopically, which I can demonstrate with a biopsy, but I left you without a scar in the brain and you are coming to blame me. When you put it across to them, then the blame game stops. At least the patient stops because you have done the right thing in the right time and you can use internet to your advantage to show them. And the last thing is about the thrombolysis in patients who have actually looking like stroke mimics. Is it really required? Now, there is a paper, for example,
I have the
2017.
case 4 for that, sir. Shall we
Okay,
complete that?
okay, then
Because
I
we
will
are
stop.
covering all the topics, all the atypical scenarios.
Sure,
Just
this
one
one.
more point. Actually, I was expecting some major vessel occlusion in one of these patients. I was expecting, see, many times we see a small infarct, but you see one of the carotids not seen at all.
We
Okay.
experience it very commonly. Yes,
Yeah,
sir.
yeah, so that's a very common scenario. Now the question is, you don't know whether the vessel block is chronic or it is an acute one.
Sure.
That's a difficult scenario. The only way is to do vessel wall imaging and see, but that may not be possible in an emergency situation.
Exactly, sir.
So that is one thing which the patient will come with NHS 3 or 4 major vessel occlusion. Everything will look okay, but they will worsen all of a sudden. So in that situation, it is all the more important to thrombolyze. So we should not hold back the thrombolysis. So that is another common scenario. And in these vessels, in these patients, since I think a couple of people are old, and the vessels are normal, probably atrial fibrillation could be one of the causes which has to be looked into carefully with hold. That's all.
Yes, sir.
Just a couple of
Okay.
messages for the audience. So in a given patient who has come out of the window or the window is not clear, she has taught us that you could thrombolyze based on tissue imaging. And this has been approved up to 9 hours if I am correct for altiplase. And studies with tenecteplase have shown improvement even up to 24 hours. That's a good data for us. In other words, we can move away from the concept of tissue window and time window and we can go to the tissue window and can thrombolyze any person provided you have talked to the family and then you go ahead if there is a salvageable brain. And this can be really made clear to us by looking at the diffusion flare mismatch which you said, or when you have a perfusion study you can do a perfusion imaging and try to see whether there is a mismatch. That was a diffuse data more than 1.8 perfusion core, or you can do a NIHSS diffusion mismatch where you had NIHSS which is very large because it is reflecting both the core and the penumbra, whereas the diffusion shows only the core, and you can use that, or a clinical aspects mismatch. These 4 can be used. So that is a learning point from your case. I would just request MQ people, friends, Do we continue with this, or we can keep Srivardhan's one more, presentation in the next forthcoming? It was 9:40. The time is. I'll take opinion from Prachit and our MQ friends. Is it okay? We continue.
Yes, sir. If we are
Yes.
okay, we
can
can continue.
continue.
Yeah, then we can go ahead, please.
Yes, sir.
Because we
Just
don't want attrition from the audience. We
Hmm.
want to keep it live, and maybe we can keep. That's the reason we asked. There is no attrition from audience, ma'am.
No, so there's only increment as the session is progressing, so we can
Then
carry on.
Shri, please enlighten us, Shri. Thank you.
Yes, sir. Just one last case. This is a patient which we encountered during the COVID times with a lot of, the COVID restrictions and isolation. 62-year-old male, diabetes, hypertension, CAD on medical management, COVID illness. He was on quarantine and isolation. He presented with an acute onset of difficulty in using the left hand. He is a carpenter by profession. I'll just show the video once before describing the findings. So basically, he had significant hypotonia on the left hand. I'm trying to ask him to make a dorsiflexion by making that movement, but he's not able to dorsiflex. On the other hand, the extension of the wrist is significantly weaker, but on the other hand, flexion at the metacarpophalangeal joint, interphalangeal joints, they are all fine. If you closely watch the video, I'm trying to stabilize the wrist and asking him to do a metacarpophalangeal joint PAP and DAP extension, which the patient is not able to freely do. So in spite of stabilization, wrist extension, metacarpophalangeal, proximal interphalangeal and distal interphalangeal joint extensions are all weak. There is no sensory deficit. If we actually use the NHSS, it might roundabout come to 1 because there is weakness restricted only to the left hand. We did an initial CT brain was normal. So this is what Sir was talking about, Stoke mimics and Stoke chameleon. At a very small or a superficial view, people might just brush it off as a wrist drop secondary to radial neuropathy. But what I was trying to demonstrate is extension at the interphalangeal joint is not done by the radial nerve. It is done by the ulnar nerve. So a patient with a true radial nerve palsy, if you stabilize the wrist, they will still be able to make PAP and DAP extension, which was absent here. So even if you suspect that we are dealing with a stroke mimic, we are 100% justified in thrombolizing. So this is one of the Western data where we can see that of the patients who were thrombolized and were ended up as stroke mimics, majority of them had seizures, post-ictal paralysis. Some of them had sepsis, toxic metabolic lesions, space-occupying lesions, syncope, delirium, acute vestibulitis, mononeuropathies, functional, migraine, they've all been thrombolized. If you see, the mean percentage of thrombolysis in stroke mimic is somewhere around 9 to 10%, with majority of them being seizures, migraine, tumor, decompensation, and functional disorders. So this is a very important statement which I want people to understand. IV thrombolysis is generally safe in patients with suspected acute ischemic stroke who have a follow-up negative brain imaging, and delaying IV RTPA administration in cases of doubt is not appropriate. Our results support the previous finding that the use of IV RTPA appears to be safe in stroke mimics, and prognosis is generally favorable and complications are rather infrequent. To the best of our knowledge, this is one of the largest reported series of patients with stroke mimics treated with IV RTPA. So, just because we have a doubt, delaying thrombolysis administration is not at all appropriate. When in doubt, basically treat them. The risk of intracerebral hemorrhage in patients who are receiving thrombolysis for stroke mimic is similar to the risk of intracerebral hemorrhage in patients receiving thrombolysis for MI, the risk is not very high unless there is a major infarct or a space occupying lesion inside the brain. So when in doubt, always treat. Even the recommendation from the American Stroke Association says the risk of symptomatic intracranial hemorrhage in the stroke mimic population is quite low. Thus, starting IV altiplase is probably recommended in preference over delaying treatment to pursue additional diagnostic studies. And when it came to our patient, anyway, we were curious. So after thrombolysis, after stabilization, after the quarantine was over, we did an MRI, which showed a small infarct in the cortical hand knob. Yes, sir. Because he wanted to talk about stroke mimic, that was the last case which he had kept.
Thank you. Thank you, Sri. It's a beautiful demonstration of a knob infarct. So showing, knob infarct as a contributory factor for wrist drop as presentation and differentiating a peripheral wrist drop from a central wrist drop, which you actually showed to us. These are beautiful things. And in fact, there is an AHA guideline which came in 2018, which said, when in doubt, thrombolyze stroke. Actually, you can thrombolyze in a stroke mimic. And the reason is because for us to have an intracerebral hemorrhage, there should be some breach of blood-brain barrier. And if there is no blood-brain barrier breach, the chance of hemorrhage becomes very less. And that's why MI and the stroke mimic will have equal risk. So HA guideline is also there. Based on the original data, Chemichio et al., Neurology, Green Journal 2010, 512 patients, of which 69 had stroke mimics. Most of them were actually conversion disorders who came to the emergency like that. And nothing happens. But one thing in our setting where the patients are paying from the pocket, there might be economic burden and they may actually blame us. So we need to be careful in making the correct statements to the family. Nothing wrong, no harm will be done to the body, but to the purse, because there will be a harm, there might be some blame games. We should exercise caution in that. But otherwise, when in doubt, of course, we go and thrombolyze them. We don't have to hesitate. It's a point we need to make. It's a great presentation, Sri, as usual.
Thank you, sir.
Satish and Sri, we learned a lot. Any other comments from Prachit?
I think both were very good presentations, learning points for all of us, and very powerful message driven across to the younger generation that probably more and more patients should be thrombolyzed. That is the aim.
Thank you. So I think we can stop here. Thank you very much for attending to this program in a Saturday evening. I once again thank you once and all and hand over to NQ for deliberations.
Thank you so much, sir. Thank you. We had really two very interesting cases, and I'm sure the audience will also be benefited. We had a total of 80 audience that were live with us throughout. So that is a very great number to start off with. So thank you so much for all the doctors for your time and for the great learnings that each and every one of you has shared today. Thank you so much.
Thank you, madam. Thank you, Sri. Thank you, Satish. Thank you,
Thank you, sir.
Prachit. Bye.
Thank you, sir.
Thank you.
Thank you, sir.